awesome. So we'll get started. Welcome, everybody. Thank you so much for coming along today. My name's Sada. I work here at Women's Health and Wellbeing Barwon Southwest. I'm a health promotion officer and currently leading the peer-to-peer birth support pilot program. I'm really passionate about advocating for systems that centre the safety and wellbeing of women and gender diverse folk. And I just really want to thank you all for coming along today. I know it can be really challenging to get away from clinical work and make the time to come along to these sessions. So we really appreciate your time. Firstly, I just want to acknowledge the traditional owners of the land that I've privilege of zooming in from today, the Wadawurrung people of the Kulin Nation. I pay my respects to elders past and present and to all Aboriginal and Torres Strait Islanders people who are joining us today. I also just really want to take a minute to acknowledge the thousands of years of traditional birthing culture that have been disrupted by colonisation and Western practices, and really commit to, I guess, advocating for and uplifting First Nations-led solutions in the birthing space, of which there are some really beautiful ones happening across Australia. So just want to reflect on that. Before we kind of get started, and I'll introduce our lovely guest speaker and panellists here today, I just wanted to acknowledge that we will be touching on some sensitive and sometimes distressing topics, including childhood sexual abuse. So please feel free to take breaks if you need to. You're really welcome to reach out after the session if you feel like you need some extra support. Just do what you need to take care of yourselves throughout the session. So it's Birth Trauma Awareness Week, and we are here because the birth of a child is, one of life's most monumental events and transitions, as you all know, working in this amazing space. But we also know that 1 in 3 birthing people describe their experience as traumatic. So for them, that transition into parenthood can be really overshadowed by physical and psychological injury. And birth-related trauma also affects not only the birthing person, but also their family, their partners, their friends, and healthcare workers who might be witnessing some of these traumatic events. So for us at Women's Health and Wellbeing, preventing birth trauma really sits within our mission because we know its impacts aren't contained to the birth itself, and untreated birth trauma can shape a person's mental health, their physical health, relationship with their body, capacity to bond with their baby, and their trust in the healthcare system and reproductive choices moving forward. So for us, prevention really has to include this moment in birthing parents' lives. We also know that women and gender diverse people and their partners enter the birthing space with a lifetime of experiences that shape their responses in time of uncertainty, fear and stress, and that childbirth is a real time of uncertainty and often things don't go to plan. So today we want to focus on what you as healthcare professionals can do in your day-to-day practice, and to really highlight those small moments that matter during pregnancy and birth that can change the experience for a birthing parent. We know we'll never be able to prevent all psychological distress or birth injury or complications, but it's really about how we respond in those moments that can shape how they're experienced, remembered and processed. So that's why we've brought you all together today, and we're really lucky to have Hayley Ballinger here and who to present to us. So Hayley Ballinger is a social worker that I'm sure many of you know, with extensive experience supporting people impacted by trauma. Her career has spanned child protection systems, trauma-informed programs for at-risk young people, and support services across the sex industry, addiction and homelessness sectors. She's also supported asylum seekers and refugees in the Philippines and Nauru, and spent 7 years working in the Southwest Centre Against Sexual Assault. So we're very lucky. Hayley now channels all of that experience into clinical education at Southwest Healthcare, and she's also a trained facilitator of the peer-to-peer birth support group that's currently being delivered in Warrnambool. I don't know how she finds the time for all these things. So she's going to take us deeper into the practical strategies that you can use. And after her presentation, we're also very lucky to have Dr. Alex Umbers join us for a Q&A session. And I'm sure many of you know Alex, who is a local GP obstetrician in Warrnambool and a passionate and active advocate for women-centred maternity care, and also the champion of the peer-to-peer pilot project down in the Barwon Southwest. So we're really grateful to have you both. Thank you so much for being here. think of some questions as we go. You're welcome to put them into the Q&A function, and we'll have that at the end of Hayley's presentation. But I will hand over to Hayley now to get started.
Thank you. Thanks so much, Sada. That was a very lovely introduction. Probably couldn't fit all Alex's resume in. You wouldn't have enough time. Like 20 minutes would go too quick. She's just sitting across from me. So, but thank you so much, Sada. And I'd just like to take a moment to thank Women's Health Barwon Southwest for all that they do, and for investing in this pilot program, and for all they do for women and families in the region. I just like to say thank you so much for being here to engage in this conversation about trauma and violence-informed care, which I'll introduce, and ways that we can support women and families. I know it's really busy. I know it's not ideal doing things in your lunch break if that's where you're coming from, so I really appreciate it. I just want to do a caveat that I am coming from this today from someone with lived experience of trauma, but also from my 17 years of working with people with complex trauma. I recognise I'm not a medical professional, not really working in the birthing space at the moment, so I have limitations to my knowledge. Next slide, please. Thank you, Sada. It was smooth. So before we talk about the small moments that can make a big difference in trauma-informed birth care, we first need to start with a shared understanding of what trauma is, and this is a broad definition. It can be understood in many different ways. One way is through the timing, duration, or nature of the experience. This involves looking at whether the experience was acute or a single incident, such as a car accident, if it's chronic or cumulative, such as family violence or child abuse, and that would be also talked about in terms of complex trauma. Another concept I want to introduce today is developmental trauma. This refers to traumatic experiences that occur during critical periods of childhood development, and they disrupt healthy emotional, social, and sometimes physical and neurological development for children. Trauma can also be vicarious. So even if an event doesn't happen directly to you, but you're witnessing events such as working with victim survivors, or you're witnessing multiple experiences of birth that are traumatic, this can also impact people, and they can have trauma symptoms. It's also important to acknowledge that experiencing trauma is different from having post-traumatic stress disorder or PTSD. Many people experience traumatic events in life without developing PTSD. Today, we're specifically focusing on birth trauma. However, previous exposure to traumatic events can increase someone's risk of experiencing their birth as traumatic. So women and gender diverse people come into the birthing space with a lifetime of experiences that shape their responses in times of uncertainty, fear, or stress. Childbirth by its nature is uncertain. Sometimes things don't go to plan. Today, we're just going to focus on what health professionals can do and highlight the small moments. I think that's that one done. So this is the slide that Sada let me keep because I dumped everything on here. But I just want to highlight that, to further highlight the importance of trauma and violence-informed care as a universal approach, is that trauma is universal, that this is not a statistical anomaly. There's many, many people that experience traumatic events, and women and gender diverse people, of course, and girls are disproportionately impacted by trauma and by adverse childhood experiences, which have been, there's been major studies that have linked adverse childhood experiences to health across the lifespan. So just, there's a few things there. I won't go into it because I've got to keep things short. But that there's one in three women have experienced sexual abuse, and Aboriginal people are 32 times more likely to be hospitalised due to domestic violence. So it's just an important lens to have when we're working in healthcare. Thanks, Sada. Due to my professional background working at CASA for many years as I did, I just want to take a moment to pause and reflect on some unique challenges faced by women who are sexually abused as children, and how this can manifest and resurface during pregnancy and childbirth. As you can see here, the statistics are really high, and research tells us that women with a history of sexual violence are actually twice as likely to experience postpartum post-traumatic stress symptoms or receive a diagnosis of PTSD, and almost twice as likely to experience postnatal depression compared to women without a history of sexual violence. there's a specific betrayal that happens during sexual abuse, and sometimes that can cause long-term injury, psychosocial or physical. And women with childhood sexual abuse histories report higher rates of chronic pain, vaginismus, ongoing exposure to violent relationships or re-victimization, and higher rates of autoimmune conditions. Pregnancy and childbirth can be particularly vulnerable times because many aspects of maternity care can unintentionally mirror elements of the original trauma. Experiences such as feeling a lack of control, being exposed or undressed, certain birth positions, vaginal exams, pain or procedures in the pelvic region, and feeling unable to stop can cause triggering memories or distress for sexual assault survivors. Reflecting on these experiences can help us to deliver care that promotes safety, choice, and trust. So this is trauma and violence informed care is a framework and it's a model, and it is it's expanding on traditional trauma informed care to include it asks not just what happened to you, but explicitly asks how do social inequities, ongoing violence, systemic discrimination also affect your well-being, and it assumes that past ongoing trauma and violence heavily influence a person's life, behaviours and relationships. It's an emerging model. It's what the Royal Women's use at the moment. So just a little bit different from just traditional trauma-informed care, but as you can see, the principles are the same. So we're going to be focusing on these principles you see in front of us: the cultural, gender, history, and identity. So it means responding to a woman's culture, gender, religion, sexual orientation, and ability, and realising the impact of racism and discrimination in healthcare and how that impacts someone's experiences when interacting with the healthcare system. Safety is paramount. We'll talk about that a little bit. It works with women to ensure they feel physically, culturally, socially, psychologically safe when they come into the hospital or when they're receiving care. Trustworthiness provides transparent, reliable, accountable, and respect and boundaries. And we try and work collaboratively together when it comes to decision making and care that is provided for women. Yeah. So in order to speak about, sorry, there's a lot here, I'll keep flowing, how we can implement trauma and violence informed care in the small moments that make a big difference to birthing women. We have just touched on the prevalence of traumatic events. So that's realising and recognising how widespread trauma is. That's one of the pillars of trauma and violence informed care. And I want to touch on how we recognise the impacts trauma can have on your patients and how they might show up during birth and after. And then I want to touch on ways we can respond in small practical strategies and also resist re-traumatization. So in order to understand further how we can respond and what kind of tailors our responses to people, we need to understand the neurobiology of trauma. This is probably not new to anyone, but I'll just very briefly touch on kind of the functions of the brain that are impacted by traumatic events, particularly complex trauma. So the amygdala is the brain's smoke detector. It's primarily responsible for threat detection, fear conditioning, initiating the body's survival responses. When an individual experiences trauma, this tiny almond-shaped structure undergoes profound functional changes and alters the way a person perceives and responds to danger long after the event has happened. The hippocampus, so that's responsible for logging memories with specific dates, times, and context markers. So they would be your explicit memories. These specific areas of the brain actually reduces in size and function after traumatic events, and that's been shown up on brain scans. And its ability to sort through memories is compromised following trauma. So it can no longer detect time, dates, and context of memories. And that can cause flashbacks and confusion and gaps in memory. The most important, not the most important, but prefrontal cortex is key. So this is what we call the watchtower. It's the only part of the brain that can actually influence these other parts of the brain and kind of talk to them and provide that emotional break to, say, the amygdala when it's firing and perceiving threat. The prefrontal cortex is the only part that can speak to the amygdala and tell that there's no threat. And I'll explain this a little bit more using, I don't know if people can actually see me, but has anyone ever heard of Dan Siegel's hand model of the brain? The reason I put this in here, it's really simple. And it's also because it is a small practical strategy, and it's a really good way to talk to patients about what's happening in their brain. And when they kind of understand, it takes away and shifts blame that they might be feeling or shame they might be feeling for these reactions they may be having that are kind of out of their control. Because what we know is that it's involuntary when the amygdala is firing. That's actually the part of the brain. So this is the way that you describe it. So this is the model of the brain here, the working model. And this is, hopefully you can see me, but this is the brain stem that leads up into like the oldest part of the brain here. And you've got your limbic system there. So this is like your limbic system. So probably your amygdala is somewhere in here. And then that's the cortex that wraps around here. This is the prefrontal cortex. And what's happening when your body or your brain is getting information from the outside world, but the amygdala is like highly sensitive because you've experienced trauma. It doesn't know how to interpret this. And what happens is you get dysregulated and you flip your lid like this. So your prefrontal cortex is gone and you actually can't control your emotional responses. And we actually need to respond to people not with complex language and complex problem solving, because that part of their brain is actually offline. We actually have to target the limbic system, and we have to target the emotional center of the brain and the nervous system. So it's kind of a handy, hopefully that makes sense, but it's a handy model. I don't have so much time. A handy model. God, that was the worst. I didn't even mean to make that joke. Okay, Sarah, I finished with that one. Thank you. This is another model. I can't go into too much. I don't want to take too much time, but this is the window of tolerance. And this is also another Dan Siegel one. He's a psychiatrist, just in case people don't know. Done a lot of work around the neurobiology of trauma. So when that lid is flipped and people are dysregulated and people have gone into their kind of nervous system responses that they actually have no control over, is that either gone into hyperarousal or hypoarousal. And I'll talk a bit about how that can present during birth and postnatally. But basically, if you're out of your window of tolerance and your lid is flipped, that's where your fight, flight, freeze or fawn response can come in. And that's what you might be looking for during your interactions with people, maybe post-birth, maybe during birth, maybe in the early stages. There could be aggression, explosive emotions. There could be a flight response. And I think I talk about that a bit more in the next slide as well. Thank you. So what does this look like? This window tolerance, this like lid being flipped. Sorry that you've lost me. Can you still hear me though? Can you hear me? I don't know why.
Yes,
where my
can hear you but can't see you.
That's perfect timing because I've done the hand model, so that's fine. You don't really need to see me as long as you can hear me. So what this window coming out of your window tolerance into hyper or hyperarousal, or when your lid is flipped, this might in postpartum or during the early signs of birth. It might be hard to tell later on in birth, but people could be experiencing flashbacks of abuse. So flashbacks feel like they're happening in the present because their hippocampus is severely compromised, and people don't realize that. People don't realize that what's the past coming into the present is what's happening. They actually feel the sensations, they hear things, they can smell things from the past historical violence or trauma. They might dissociate. Dissociation is not an enemy necessarily, it's a protective mechanism, but that might look like people kind of staring into space really blankly. They could, the best way to kind of just describe dissociation is like you feel like you're out of your body kind of looking in, you feel like you're not part of your body anymore. And it can be a protective mechanism for people, but I would say if you see someone that's dissociated or having symptoms of dissociation after birth, that might be a little bit, something to kind of be curious about. Again, that fawn response from that previous slide, also an involuntary trauma response, probably from someone that's experienced childhood trauma potentially, is that they can't fight, they can't run, they either have to freeze and dissociate or potentially please the person that's abusing them in order to stay safe. So passive compliance is not necessarily a good thing. If someone is overly compliant, that could actually be a trauma response. They can revert back to childlike behaviour. We talked a bit about developmental trauma. That's how it could potentially present. They could revert back to the behaviour of maybe the developmental stage at which they experienced previous trauma. They might feel intense fear, panic, helplessness, out of control. That's kind of out of context. So maybe they're not going through transition, because that's probably what everyone feels during that time in labour. It's, you know, it's a little bit out of context, and they are appearing like they're really afraid. They might be avoiding, so it might be the first time you've seen them. They haven't really come to many appointments. That's a really common presentation. The other presentation to watch out for in regards to previous traumatic exposure is addiction. It's highly correlated that if someone has addiction and maybe they're struggling with it, use during pregnancy, that's probably because they're struggling with traumatic experiences, probably complex or cumulative trauma. Hypervigilance, intense emotions, difficulty sleeping or concentrating. So this is like more post kind of birth, and then feeling disconnected and trouble, connecting with and bonding with the baby, maybe trouble with breastfeeding following the birth. Not an exhaustive list because we don't have so much time, but hopefully that gives a little bit of context. And I'm just going to share my birth stories. I have 2 birth stories. They're not too gnarly, don't worry, but I'm going to use them hopefully to humanize and give an example of like something that can happen internally due to past experiences. This is my really cute little boy, Finn. He's like, it's a pretty cute photo. I'll give the short version. My first birth, I was super prepared. I was not very stressed. I was a little bit stressed, but I had time. My partner and I went to hypnobirthing. We practiced all the hypnobirthing tactics. We had the TENS machine. My partner was practicing the Rebozo on me. We were really prepared in a really good frame of mind. I was just lucky that everything was going well with my pregnancy as well. I didn't have any hyperemesis. I was feeling well. I was on the CMP program and I had a student midwife. So I had continuity and I knew my midwives. And I was induced on my due date, which wasn't what I wanted, but then everything progressed and I was really lucky that everything progressed, with no emerging issues, and I was able to deliver vaginally, and everything went okay. I think the reason, that I felt really good was that I knew my midwives. I felt really safe with them. They were very validating in my moments of kind of vulnerability. I remember feeling like people really respected my dignity. I remember feeling like there was lots of privacy, and I had really good advocates in my midwives because I knew them really well. Also, my student midwife was a bloody legend. She was really, and it was really good to know her because I knew her really well by then because she came to all my appointments. So that continuity was really important for my first birth. And then my second birth. Thank you, Sada. And this is my other baby that I had not long after my first. So it was in the middle of the pandemic. I was really tired. There's so many factors at play for me, which we don't really need to go into. But I was working. I was tired. I had a little boy at home. I was not in CMP. I wasn't prepared mentally. I also had a bit of kind of shame, I guess, around I was working at CASA as a clinician. So I didn't really disclose that I had a history of sexual violence myself. And I did not think that would be an issue for me at all. So really the staff didn't really know. I had no special kind of birth plan in place. I just went in there to, just to get it done basically. But I went into spontaneous labor at home, which sounds like the dream. But I was really anxious, and from the start of labor, I was having intrusive thoughts. I was having I was feeling like fear was creeping in on me, even in the early stages of labor, and I couldn't stave it off. And the fear triggered me basically. That hippocampus and my amygdala didn't really know that it was not happening, that I wasn't under threat during birth. And so I thought that I was. I pushed really hard at the end. I had a tear. I've still got some, pelvic floor kind of injuries, but it wasn't even a really bad tear. But the difference for me was that I dissociated during birth. I felt like I can't even remember half of it because I left my body. And then the pain kept dragging me back into my body, which was not a good experience because I just wanted to be detached from my body. My brain wanted to be. And then things that, didn't go so well, I don't want to talk too much, but was that there was lots of people in the room. I felt so exposed. I did not want to be naked in front of people. I definitely didn't want people kind of around, my pelvic region. I just wanted to have my legs shut and no one else, but I still had to deliver the placenta and have stitches. There's also multiple people were consulted whether I needed stitches. So multiple people kind of looked at me. All the while I lost my voice. I couldn't really speak, but I think that my physical body was definitely clenching and not wanting anyone to kind of be near me. And the whole environment was overwhelming. I didn't really know the midwives. I'm sure they did a beautiful job. They were so affirming, but I just didn't know them, I think, because I didn't have that relationship. And I actually had a resurfacing of PTSD symptoms following that birth, even though everything went well on paper. And that followed me around for a few months. I'm okay now though, so don't worry. But I just want to highlight factors such as safety, trust, continuity, preparation, and past experiences, and how they can all kind of compound and show up in the birthing space. I'm going to take too much time, sorry guys. So how we respond and resist re-traumatization or trauma being embedded in someone's neurobiology following an overwhelming event, trust and safety, as we've just spoken about. Many studies, I've read many studies about this, they say that when there's trust and rapport with a midwife, such as in the CMP program, birthing experiences, they experience less medical intervention and generally do not report re-traumatization. So I think I've kind of reflected a bit on my experience with that. So we'll talk a bit about practical things and how we can implement trauma and violence informed care principles. One of the most important practices that you can uphold for survivors of violence or for adverse childhood experiences, or just for anyone really, is true informed consent. Always consider cultural, intellectual, considerations. Do people understand what you're saying? Is the information being provided in a way that they understand? Check their comprehension. Do they understand what you said? Can they kind of relay that back to you? That they are provided time to make the decision if it is, if you can provide time, if it's not an emergency situation, that they can actually think about things. That's choice, that's empowerment, that's collaboration. And verbal consent is obtained, not assumed, for every new procedure or exam. And it's an ongoing thing that you're constantly negotiating. Is it okay if I do this? How do you feel about this? This is what we're going to do next. What do you want? How do you want to proceed? And you understand, consent is dynamic, and that being overly compliant is a trauma response, can be a trauma response. Another important thing is the environment, because it's about creating a psychologically and physically safe environment. Because if someone has a hyperactive, oversensitive amygdala, the brain is already, and this could be they've had a traumatic birthing experience previously, and then they've come in to deliver their second, third, fourth baby. The amygdala is going to be scanning. The brain's going to be scanning for danger at any site and in the environment, and that's likewise for neurodivergent people. So some of these things can really help, limiting noise, limiting the amount of people in the room, knocking before you enter the room, because it gives a sense of like, this is your private space. You are private, you are safe in here, and we respect that kind of space. Dimming the lights, you could mute the hallway noise if you can. I know this is stuff that people do anyway, so thank you. Choice and control are essential components to trauma and violence informed care. So here's some advice. Also, this is drawn from the research and the evidence as well. So give patients control of the green light, red light to start and stop procedures. You could say something like, if you want me to stop at any point, raise your hand, or stop and I'll stop immediately. Some people might feel like they can't say no, that they can't assert themselves. So I think it's really good to have that kind of conversation about, how do you want to tell me when this is too much for you? Do you actually want a green light to hold up, or a card, or do you want to have a code word, or do you want to just raise your hand? So it's not too onerous for them to speak up within that power dynamic, especially if it is a doctor, because people usually do feel a bit more intimidated of doctors, and there is a bit more of a hierarchy. Whenever possible, provide a female, if there's a female doctor or a female obstetrician, that would be preferable, for especially if you know that someone has a history of sexual abuse. However, it's not necessary. When entering a patient's room, introduce yourself and the upcoming procedure at eye level if it's culturally appropriate. Again, this is about leveling the playing field, and it's about really taking the time to connect with them and make them feel like you're collaborating with them and building trust and building safety. Because if someone's standing over you all the time, like, people can internalize that and see that as a power dynamic, and then they're less likely to speak up about what they need if things are starting to go wrong during birth. And if there's a birth plan, try and read it if you have time, and discuss it if you have time with patients, and validate their choices as far as is possible. And obviously things change, but also to validate, I'm sorry things didn't go to plan for you. Thanks, Sada. You're right on it. Really important one, minimizing invasive procedures. Not always possible, totally understand that. Start with the least invasive methods of labour induction if you can. Also, you can probably give choice to people so they can choose kind of what's going to be best for them. Limit the number of people in the room, as I've mentioned. Limit VEs if you can, and breast exams, well, vaginal exams in this case. Unless you really need to do them. If you are going to do them, engage with informed consent. Because that can be really triggering for people with a sexual assault history specifically, but for lots of women. Only ask them to remove clothing items, and this is for every woman. This is not necessarily for people with a sexual assault history. Like, dignity is really important, and cover the patient between procedures. I know this is stuff people do anyway. Avoid opening the patient's legs, invite them to kind of move them aside when they're ready, and give them time if you have time. And always provide a full description of a procedure, maybe in language that they can understand in advance, including any anticipated pain or discomfort, because it's good for people to know, because if there's pain that is not anticipated, that can leave a mark in the brain and the body following birth. Not a physical mark, a psychological mark. Okay, this is some examples of how trauma-informed language matters. We might share the slides or something. I don't know, I'll pause on this because I'm just aware that I've got I've got a bit more, and I really want the Q&A because Alex has amazing things to say. But these are some examples. Like, would you like me to explain the examination I'm about to do before we proceed? Would you be open to? What are your thoughts on trying? Like, that invitation of collaboration and choice. Who would you like involved in your care and decision making? And that could be around cultural safety. Like, what does an Aboriginal woman need? Sada, we'll just keep moving just because 45 minutes for me. Asking a woman to breathe doesn't have to be just a tactic or something that you use during labour or birth. When our brains have been triggered and our lids are flipped, we respond best with co-regulation to this part of the brain, and strategies that target that part of the brain. So deep breathing actually sends, all the signals from the nervous system to the amygdala, tells it, because we can't tell it because the prefrontal cortex is offline, but the body can tell your amygdala and that part of the brain that you are safe, you are okay, and then that can bring the prefrontal cortex back online. And then people are more likely to be able to engage in complex decision making and give informed consent once their whole brain is working together. And these are just some examples of breathing strategies you can try. It's important to remember that trauma does not determine a woman's birth experience. Many women with histories of childhood trauma describe pregnancy, birth, and the postnatal period as life-affirming, empowering, and healing. In my work, I've had the privilege to speak to many women about their birth stories, and many women remember the way that their care team made them feel. They say things like, I felt heard and safe. I loved my midwife. My doctor really took time to explain things to me and it helped my anxiety. I felt validated. This is the things that I hear from women. Despite the circumstances, whether it be an emergency surgery, a child rushed to the NICU, or a serious postpartum hemorrhage, they tell the story of the event, but it is mostly reflections on how they felt and how people around them spoke to them, treated them, and supported them. Every interaction matters, every conversation, every explanation, every moment of kindness, and every opportunity to offer a choice can shape how a woman remembers her birth. You already make an enormous difference. Thank you for everything that you do. And thanks so much for taking time today. I think we've still got time for questions. Sorry if yes. Thank you.
Well done.
I'll mute myself.
Thank you so much, Hayley. That was a whirlwind of information, so much in there. No, it wasn't too much. It was fabulous. I hope we'll definitely send around the slides and the recording so people can kind of go back through some of those things. Really, thank you also for sharing your own lived experience. I really appreciate how vulnerable that can be. And I think it's really important that we keep listening to that lived experience to help shape the care that we give to birthing parents. I'm sure that there will be some questions from our lovely attendees. But while that's kind of happening, I might get us started with you, Alex. So when there's a clinical emergency or things move kind of quickly and don't go to plan, how do you as an obstetrician balance that need to act fast while also keeping the birthing person informed and feeling in control?
Yeah, thank you for this question. It's one of the great challenges of working in the birth space is you've often got things that emerge at different paces. It's a dynamic environment. And a lot of the time we can anticipate which way things are going to go, and other times it's just things just show up unexpectedly. So it is a really delicate thing to do well. And I think some of the things Hayley touched on, or even I'm learning things from her about informed consent and how to co-regulate and really keep that leveling with your patient at the front of mind. A lot of the time in obstetrics, there's not, you've got 3 or 5 minutes to have a conversation before your next step. And sometimes I get off the phone to my friends and look at the time we've spoken as 3 minutes. So we've covered a lot of things in 3 minutes. You can actually cover a lot. So I think we as clinicians, the temptation is to rush through it and do the task because we're very task focused. But I think it's important to helicopter out and say, no, we do have time to have a robust discussion. So I think, yeah, pacing it, assessing the situation, what is the time criticalness? I don't know if that's a word, but you know what I mean. And using body language and tone to really allow the woman or the birthing person to feel safe and supported and to provide the right amount of information, and that will vary for every person for their circumstances. No two births are the same. And I think tailoring it to the person's needs. But beyond this, I think all the decisions that happen in labour the discussions need to happen in the antenatal period. This is the time where there's no time pressure, there's no emergency. You can't cover off everything, but having really good quality antenatal education, having that continuity is probably my number one so that we can understand our patients. They feel safe disclosing anything that may be relevant to their birth preferences in advance so we can help best support them. And then if things do emerge in the birthing space, there is that knowledge of what may be best suited for that person in that particular moment so that nothing's rushed. But I could think about that forever. But yeah, those are my initial thoughts.
No, that's a beautiful answer. And I definitely agree. I think some of working as a nurse, some of the best doctors that I ever worked with were the ones who would come into a room and they give this sense to the patient that they have all the time in the world, even though, they've got like a million things waiting for them the minute they step outside that door. They just give the sense of time, and that like calms people straight away. And I think that's such an amazing skill and something that everyone can kind of practice, just like slowing yourself down in those moments. So that's really great. Thanks for those reflections. I do have a question actually from Chloe in the Q&A, which kind of touches on that continuity. So she's asked, I don't know if either of you will know this for certain, but are women who have a history of trauma prioritized in the CMP MGP program at Southwest Healthcare?
It's a really great question. I think I can't comment on the specifics, but I think I know they prioritise first-time mums and anyone with social complexity. So I imagine it would fall within that. I think as an employee of Southwest Healthcare for 5 or 6 years now, I really know we don't get it right every time. We're all learning as we go. We work in an imperfect system. But I think there are people that work here that are trauma informed and are interested in working in this space and being on the front foot. And so I know working up on level 4, if there is a patient with a complex history, they are really prioritized for continuity, be that in the CMP or GMP as it's called now, or you can still get that with continuity of doctors and midwives on level 4 in our local region. I think in the media, the gold standard has been to promote midwifery-led care as the only model of continuity. But for me, it doesn't matter what kind of continuity people get, as long as they have that continuity. It's very protective for birth trauma.
Yeah, amazing. Thank you. I guess we've talked a lot about like the individual experience, but I guess for both of you, but I know that you probably have some thoughts on this, Alex. But what do you see as like kind of the broader health system costs when prevention's not prioritized for birth trauma specifically?
Yeah, well, interesting you mentioned that, Sada, because the theme of this week's Birth Trauma Awareness Week is the cost of birth trauma. And Birth Trauma Australia are a wonderful organisation that have been advocating in this space for a decade now. They've just released a report on the cost of birth trauma, and in 2023 to 2024, $17.4 billion. That is equivalent to the cost of endometriosis as a direct comparison. And you think about all the resources, and rightly so, the resources that have gone into research, into care, into specialized pathways, training our healthcare professionals. Like, this is a very similar costly issue. It affects individuals, families, their capacity to return to work, their ongoing healthcare needs, the healthcare system. So it is a very real issue. And I think now that report has been tabled, our politicians and decision makers cannot turn a blind eye to this issue.
That's so great that they've done that, and it's like, yeah, a published report that now is really showing that cost. And I think, unfortunately, with politicians and things, sometimes we need to speak in financial terms. So it's great that we have that evidence now, and that is, yeah, really alarming. But I guess is a reflection of how important that this work is, and that everybody in this room can take some of these strategies and implement their day-to-day practice to try and help prevent some of that birth trauma from happening in the first place. And I guess just to end on maybe one question for both of you, I guess, you know, we know that things don't go to plan sometimes, and we can't, in the moment, we might have missed that moment, you know, during the birth or labor, where we could have stepped in because things were happening so quickly, it was emergency. So how can we really validate a birthing person's experience so that they don't walk away feeling dismissed or unheard, which is something that we hear a lot from birthing parents?
Well, I'll start, and I'm sure Hayley will have some beautiful insights to share. But I think I really want to convey that birth trauma, when it does occur, looks different for everyone. No two stories are the same. So we have to be mindful about not sort of taking that leap of faith that a one size fits all is going to work for everyone. From my own lived experience in working as a GP with an interest in this area for a number of years, when there is a traumatic birth, it doesn't always show in those first few days or even months, because there are so many competing priorities for mum. She's learning how to breastfeed, she's learning how to settle her baby, she might be dealing with injuries. There's like so many appointments in those first few months that often, like many women's health issues, the birth trauma just goes on the back burner, right? It may not reemerge until she's pregnant the next time and thinking about birth. So I think it's really important in terms of validating to have that lens that it can emerge at any time, and that, as Hayley beautifully illustrated, what looks normal on paper can still be traumatic. So having an open mind, screening for it, early detection, and if there is something that has felt traumatic, that we see it, believe it, and respond to it appropriately. There's lots of pathways. We've got some perinatal psychologists locally. We have our birth trauma peer support group that Hayley runs. And I think I would love everyone to be trauma aware. Unfortunately, we're in a system where that is not possible. But I think really listening to your patients and having time and space for these issues to emerge is probably the key thing for me.
Amazing. Thank you. I just had someone submit a comment on that as well, and they've said, please know the birth trauma is felt by the midwives and doctors as well. We see it, we feel it, and we do our best to support mum and baby during emergencies while respecting the woman and her needs and past.
Sada, we just turned you off mute both by accident. So I think Hayley was going to add something to that.
I was just going to...
That was
Sorry.
That's okay. That was a really beautiful comment from one of our attendees. Apologies.
Sorry, Alex and I are in the same room.
Audio issues.
Have you noticed? I just want to, did you just see, I just want to recognize that who just spoke in the chat. Absolutely. That's why I mentioned vicarious trauma at the start, and I wish I had more time. I want to recognize absolutely that, and I know it's not the same, but, even being exposed as I was at CASA, to people's traumatic experiences, we need to look after our workforce, and the trauma-informed model actually is for encompasses staff as well. So thank you so much, everyone. We appreciate you so much. If you are needing support, please reach out. This does impact staff, and we want to keep we want to keep people well in the work, so please reach out if you need anything. Happy to do a session on how this impacts medical and healthcare practitioners.
That could be wonderful.
So thanks for sharing that. We're probably running out of time, I think.
Yeah, I think we might wrap up. We've gone a couple of minutes over. Thank you, Hayley and Alex, so much for being here and giving us your expertise and knowledge. I feel like between you, we could talk about this all day. But yeah, really appreciate your time. And just as Alex mentioned, just wanted to remind everybody that registrations are open for our Warrnambool peer-to-peer birth support group. So if you have any people in your networks that you think might be interested or that would be a good fit, please feel free to pass it on to them, and